Convalescent plasma. What is it? Well, you have a COVID patient, they recover, you draw blood, there will be virus neutralizing antibodies in their blood. You purify down the serum plasma, and then you can give it to doctors and nurses that are treating COVID patients, and that is prophylactic, and I'll explain why it's prophylactic on the next slide. Or you can give it to patients who are sick. The studies show that the patients that come in with the initial deterioration symptoms, that means they're having difficulty breathing and they have a intractable fever, okay? But they're not at the stage of the cytokine storm and the shutdown of systems, and you need to prone them and vent them, and all, not that stage. I'm talking about they've been sick for 4 days with intractable fever, and now they're having difficulty breathing, and they come to the hospital. At that stage, when you give them convalescent plasma, it seems that they do very well, okay? And even in some patients that are really at the edge of death, as a last-ditch resort, about a third of those patients respond to convalescent plasma. Now, everybody in between, we still don't have enough data. We don't know whether it's effective or not. Now, why? What is going on here? Well, it's very complicated, but think of it this way. Not everybody who gets their blood drawn who has recovered from COVID will have the same level of neutralizing antibodies, okay? And right now, and we talked about this over 3 months ago when this first came up. You can't dilute the plasma. So you can't get a bag and give it to 10 patients. It has to be a one-to-one therapy, okay? So one patient receives it from one donor. And the reason for that is titration and all this other stuff, and the duration of which they have to receive the therapy. We won't get into the details of dosage and all that, but just think of it this way. Let's say all of us on the panel, Terry, myself, Karen, and John, all get COVID and recover, okay? Maybe my recovery was 4 days, but Karen's was 12. Maybe I got a very mild case and Karen actually suffered through fever and cough and all of that stuff, okay? The measure of your sickness is also going to be somewhat correlated to the measure of your neutralizing antibodies. And it's directly proportional. So the sicker you got, the more powerful your immune response and higher titer or concentration of neutralizing antibodies will be able to get out of your plasma. If you had a mild case, then more than likely all of the really complex stuff that ends up activating T cells and all and the B cell response, that didn't kick into full fifth gear there. It just kind of helped, but your innate response and other factors, including the fact that you had a much lower viral inoculum, means that the concentration of your antibodies for those recovering from a mild case is going to be much lower than Karen's who had a worse case, okay? Now, we actually completely ignore that right now. So we just pool all of that, all of the patients as one characteristic. They recovered. We don't say, okay, here's the group of patients that recovered from severe disease, moderate disease, and mild disease. We just have plasma. And now when you give that to a patient, you're not matching them with their case status. So I'm not giving mild plasma recovery to a mild plasma patient. I could, in fact, be giving a mild plasma recovery patient donor to a severe patient, and therefore I will not be having a maximal effect with that patient. Do you understand? So this is why the FDA said, wait. We don't want to really approve this yet because the safety characteristics are not all fleshed out, and it's not fair to all patients to say that this is going to have a 37% reduction across the board, because we don't know that. In these 19 patients that were studied, the results were remarkable. Okay, but let's go back and find out who they got those antibodies from. What were the actual characteristics of the antibodies they got? Okay, and then you need to kind of dig deeper and dive down into effectiveness and all that stuff, because they were not only that, there were different dosage regimes. Okay, some were 200, 300, 400 ml in one dose. Some were 900 ml in 3 doses over 7 days. Some were 2,400 ml in 8 doses over a month. Anyone want to guess which one's the most effective? Which one's the one the FDA is pushing? Okay, this is the problem with pushing a therapeutic out and glossing over the details. This is the problem with pushing remdesivir and under emergency use. Now, their argument is that people have a right to try, people are dying, and at this point, we're trying to save as many lives as possible. And to that, I must say I largely agree. Okay, but the counterpoint to that is these are being dispensed with perhaps some false promises attached. Not every patient that receives remdesivir is going to see a 31% reduction in their length of stay. Not everyone who gets convalescent plasma is going to see a 37% reduction in severity of symptoms and recovery time. Now, if I give everyone with a headache a 500 milligram Tylenol, for most, for all intents and purposes, that Tylenol is going to work effectively because it has Tylenol. It has Tylenol in it at the measured concentration, and it is deployed to the patient with that measured concentration. So it's going to work. It's going to reduce pain and it's going to reduce fever. Convalescent plasma, we don't know yet.
So I have a question about this.
Okay.
So I understand that you don't want to give something that isn't definitely proven to work. But out of all of the therapeutic things that we could give people, does this have the least downsides? I'm just thinking about this,
Sure.
the H word, and that this can get really complicated with people that might have cardiac issues, right?
Yes, correct.
Does plasma treatment have something that I would not know about that is risky to people?
For the most part, it has the lowest risk of side effects.
Okay.
But again, like, we can't say that is 100% true. There is a risk that the screening process and the preparation process is not uniform for everyone who's had plasma collected from them, and therefore we could potentially introduce other infectious agents along with it. We could also introduce something that could cause anaphylaxis in that patient, so they'll get a severe allergic response. There's definitely, we can't say there's zero risk, but it compared to just giving, antibiotics or anti-parasitics or anti-whatever malarials that have known cardiac side effects, known whatever, convalescent plasma is somewhat safer. So that is a good question. Okay.
Could I ask a question real quick?
Yeah.
And I understand with the different strains, for convalescent plasma that would cover all strains.
Oh, Terry is now graduating to a molecular biologist thinking. He's thinking along the lines of a molecular biologist. Okay, so great catch. If you're pulling all of this stuff and you've anonymized it, You will not know whether you're getting plasma from a patient that got infected in California or plasma from a patient that got infected in New York. And it is not strain specific. So you could potentially get plasma from someone who suffered from a completely different strain that you're suffering from, or someone that got infected when that mutation that we talked about, D614G, was not prevalent. And so their plasma is totally not effective. Yeah, absolutely. Very good.
The thing that popped that into my head is, you know, of course, there's another story in the news about someone who's reinfected with a different strain.
Yes.
So I'm thinking convalescent plasma and a different strain. How effective could that possibly be?
It wouldn't, it's exactly, you nailed it, because it would not be effective. What we're looking for, and I think there's a good segue to what I'm going to talk about next, is um, these are emergency solutions, right? As we have grown more sophisticated with treatment, we can set aside emergency treatments and more, uh, do more precise treatment. And one of the things that Terry caught is that this is a scatter shot method. Okay, if you can use a rifle, versus using a shotgun. And when you're giving convalescent plasma, it's a shotgun, right? These pellets are going to just go out like this into the patient's body. And what we're hoping for soon is that therapies come forward that are based in a molecular medicine world where we're targeting the virus, okay? And we're targeting the virus that's in the patient, not the, this whole population and subpopulation of strains that are out there. And if you give convalescent plasma from a patient that suffered from a different strain as the patient you're treating, it's it's a very shotgun method, and it's going to miss all, if not, you know, the virus is just, those antibodies are not going to be useful.
Deborah has a good question in relation to this. So she's asking, when you talk about the efficacy of different doses of plasma, is that solely due to the number of antibodies, or do they differ in some other ways? Some more active against the virus than others?
Both. So what Terry mentioned is it's not just the concentration of antibody that's in the plasma, which is what I was talking about, based on the dose, the inoculum and response. So severity of illness predicts the amount of antibody response in that particular plasma. And then the second thing is called specificity. So specificity is, are those antibodies that are in that plasma specifically going to go after the virus that's in that patient that you're trying to treat? And so that is going to be in question as well. Concentration and specificity of convalescent antibodies determine efficacy. Okay, so you need a good quantity, and they need to be specifically, sticky for the virus that you're trying to treat.